So we're talking about nutrition. Well, we're talking about the concept of metabolism, but for our level and everything else, we're really looking at nutrition. Metabolism, you're going to be getting more along that, with diabetes, liver problems, and things like that as you go through the curriculum. But on the basic level, we're talking about nutrition, okay? So, what do we know is the building up of more complex substances? What is that word for building up of your body mass, complex substances, and everything else? Anabolism. What is the breaking down? Catabolism. Okay. So what patients that you took care of this week had problems with nutrition? Did any of them were in a decreased nutritional state or something? What was yours?
She had multiple fractures and she was not eating properly and she wasn't putting much in that.
Okay, so she wasn't eating much because of pain, or she just didn't have an appetite? Okay, and what about yours? Okay. Oh, good. Okay. All right. Oh, okay, good. All right. So patients who have really severe nutritional problems or can quickly develop severe nutritional problems and everything else. Okay? So for our definition, we're just doing all this preliminary stuff and everything else. Your definition is metabolism, that it describes is that the process of biochemical reactions occurring in the body's cells that are necessary to produce energy, repair cells, and maintain life. Okay. All right. I'm sorry. We're going to go back to this for a second. All right. So we know that we need cells, we need nutrition for tissue repair, maintenance, our ability to recover, our ability to fight infection, all of those kinds of things. Poor nutritional status is going to delay healing, delay recovery, and everything. So it's very important that our patients are nutritionally satisfied and get a nutritional intake that they need, that supplies their needs. Disorders, of course, of the structure and function of the endocrine glands and hormones can make a difference when we start talking about more metabolism than nutrition. So let's look at those alterations in concepts. Acid-base, if you're not being adequately nourished and everything else, it can mess up your electrolyte acid-base balance. Perfusion is important. Oxygenation, like with ascites, for patients who have liver problems and everything else, may have ascites, and the accumulation of fluid will compress their ability for their lungs. Stress and coping, of course. If they're having stress and coping for some reason, they may lose their interest in eating and all. All right. So for a few minutes, we're going to look at nutrition in general. All right. And what does food provide? So when you think of food in general, what are some of the things that food does for us in our bodies? Yeah, but what does it do? Gives us energy, okay? It maintains our body temperature, all right? It is important with homeostasis. What else do we need for children and as you grow up? What do you need for nutrition for what? Growth and development. This thing is making noise. Cellular metabolism. When you start thinking of the cells themselves, all the way down to the cells. Synthesis and repair of tissues and all, right? So what are our essential nutrients? Carbs, proteins, fats, okay. What else? Vitamins, minerals, and what else? Something we don't often think of as a nutrient, but that's water, okay. What's our most important nutrient? Water. Yes, it is. It's considered water, okay. All right. Which ones produce energy? Carbs, fats, and proteins, if we get to the point where we have to start breaking down muscle mass and everything else, okay? How many calories does carbohydrates produce when it's burned? 4. So protein supply, carbohydrate supply, 4. What is our most calorie dense food? Fats. And how many is that? 9. Okay. All right. So what are our fat soluble vitamins? A, D, E, and K. And so your water soluble vitamins are B and C. Do you know how many B vitamins we have? How many different kinds? Like 8 different B vitamins. Okay. So just to review, these look like healthy choices, right? Okay. So when we start talking about alterations in nutrition, it's anything that occurs when the intake is significantly decreased or increased. All right, because we can have too little or too much. All right. So for malnutrition, we know that the weight of the person is below what it should be, what the normal weight should be for their age and body frame and everything else. And what do you see? Their general appearance, their decreased muscle mass, they may be very fatigued, have no energy, nails are brittle, their hair is brittle and dull, and what else about their hair? It may fall out, okay? That the hair comes out easily. Like I said, fatigue, swelling, because you don't have those proteins holding the fluid in the intravascular space. So if you don't have those proteins, the fluid's just going to be going out into the interstitial tissue and everything. What else might you see in patients who are very malnourished? Okay, well, yeah, large stomachs and everything. But what happens to them? What do you need to make antibodies? Their immune system is messed up. So what do you need for antibodies? Proteins. They don't have enough antibodies, so what happens? They get frequent colds, other frequent infections and things like that because their immune system is not up to par because of their protein level and everything else. And so when do you see these patients who are malnourished or have malnutrition? Oral trauma, maybe severe burns, severe infections, someone with a stroke who can't swallow, they have difficulty swallowing, they have that dysphagia, swelling or anything in the oral cavity, maybe different cancers, neurological and muscular diseases, GI problems, or maybe if they're intubated for a long period of time. So all of those patients are at risk for malnutrition. And of course, when we think of malnutrition, often we think of these conditions in third world countries where there is just skin and bones, but they have that large abdominal area because they don't have those proteins in their blood supply to hold the fluid in, and the fluid goes out and they have the ascites. All right? So often you have that with the large abdomen. So who's at risk? We know, of course, all individuals are potentially at risk. Their socioeconomic status may make a difference, their race, ethnicity. But what populations are at risk? The very young and the very old. Okay. So the very young have immature organ systems, immature organ development. They don't have good GI digestion, absorption, and everything else. And what else about the very young, like babies and everything? They are dependent on someone else to feed them. Yes, they're totally reliant on somebody else to provide their food for them. All right. So what about the elderly? Of course, we know that their GI system slows down. They may have trouble with taste, their appetite might change, all of those kinds of things that put them more at risk also. All right? So genetics might also put an individual at risk, and they may have some genetic disorder, like some type of intolerance, like babies with PKU, all kinds of different things nutritional-wise that they can't process foods and everything like they should. Lifestyle, what is some of the things that you think of as far as lifestyle that will affect our nutritional status? Alcohol and drug use. Someone who is very sedentary, someone who eats fast food all the time, all of those kinds of things, okay? Someone who follows all the fad diets. Like you hear about one diet, you follow that one. You hear about another diet, you follow that one. You know, everything else. Inconsistent eating patterns. What of your patients this week didn't get their food, like, you know, breakfast, lunch, and everything else? Did all of them get breakfast and lunch and everything? Or why not? They didn't want, she didn't want to eat. Kept going for tests. They're NPO, they're not there for the meal, or they're not there for the meal, they're NPO, the tray's sitting, when they come back, everything is cold, and, you know, and they don't want it, their appetites and things like that. So possibly things, food code, going for the test, being NPO for prolonged periods of time and stuff like that. All right? Conditions that impact their oral intake. When you think of babies with cleft palate, maybe any type of surgery or trauma to that oral area, they might have their teeth wired shut, anything like that that's going to impact their ability to intake oral, you know, have an oral intake. Also conditions associated with impaired digestion, like lactose intolerance. Your patients who are diabetics sometimes suffer from a condition called gastroparesis. Means that their stomachs essentially lose the musculature and everything else, and the stomachs don't empty, like paralyzes. And so the food builds up in their stomach, they nauseated, they vomit, and they don't have digestion. Because remember, most of your absorption and all takes place in the small intestine. So they have problems with that. Also impaired absorption. Patients maybe who are hypo or hyperthyroid, who have an increased metabolic rate, increased caloric need. They just don't have the absorption that they need in order to meet their, what they need. All right? So let's look at lifestyle and everything else and the developmental factors. We know that infants through school age, let's look at infants first. What is the most important thing for infants? Breastfeeding, okay, for at least minimum the first 6 months, okay? It reduces food allergies. It reduces intolerances of certain foods and stuff. It's easily digested. There's fewer infections and everything during that time if they are breastfed, all right? Infants should not be given cow's milk in the first year of life because it puts too much of a strain on their kidneys. They cannot process it, and it's a poor source of some vitamins that they need. So even if if you can't breastfeed, or, you know, after you finish breastfeeding or something, if they're still less than a year, it's important that they get the infant formula, because that is formulated for a baby to supply all the nutrients and everything else that they need. And they shouldn't be getting cow's milk and stuff. All right? All right. Yeah, 6 months. Minimum of 6 months. I'm an advocate of breastfeeding as long as you can. Not like 3 or 4, but all right. Adolescents, what happens? Oh, I'm sorry, toddlers. Toddlers, it's important with a toddler age that you introduce different foods like every 4 to 7 days in order to see, can they tolerate this food? Are they allergic to this food and everything else? Because you don't want to give them peas, carrots, meat, and corn all at the same time, because then if they have a reaction, you don't know what they had a reaction to. So maybe, you know, meat one day, 4 days, 5 days later, you introduce peas, you know, so introduce gradually. All right, school-age children, their growth is slowed. You know, infants and toddlers, their growth is like so fast, so fast, so fast. But school age, their growth is slowed and everything else, so it's a more steady growth that they go through. All right, adolescents, we need that increased energy and everything else for puberty. Higher metabolic needs, more proteins and all that. Calcium. What happens, though, during puberty sometimes, that adolescent age, I should say? What's the problem that develops? Or problems? What? Yeah, well, you can't tell them anything. But what's some medical problems that occur? Or eating problems, I should say. Anorexia, yeah, bulimia. You know, this is a time when self-image is so important. Their bodies are changing. They don't like what their body looks like. They go on these starvation diet. Anorexia, they don't eat anything because they look fat, and they like so skinny and everything else. So the eating disorders become a problem during those adolescent years. Okay? All right. Young and middle-aged adults, they're just, you know, sort of going along, except if the woman becomes pregnant, then her nutritional needs change, or if she's lactating, her nutritional needs change then, and everything. And then, of course, your older adult, dehydration can become a problem with them, you know, during that time because they don't have that thirst stimulus that, you know, people usually have. So that a lot of times they become dehydrated. They may be on a fixed income where they have to not buy food at the end of the month because they have to pay the light bill, you know, or something like that. We've heard of, you know, some of you elderly eating dog food. Well, you know, they also have problems with dentures maybe. If their dentures don't fit good, can they chew? Do they have trouble swallowing? Is their smell changing? Is their appetite decreasing? Do they have different changes in their taste and everything that's going on? All right. And the elderly, you know, may need at this time vitamin and mineral supplements because their diet is not meeting those needs that they have. Okay? All right. One thing that is available for your elderly on a lower income is what's called Meals on Wheels, where they are supplied with a hot lunch and everything at lunchtime with a sandwich for the night. And I think it's supplied like 5 days a week. So, you know, if they are, you know, eligible for that, it's a good thing. Okay? All right. Let's look at a few other things. I'm sorry, going back. All right. Sex. What is the difference between a male and a female with their needs and everything else? A male, because it may be more muscle mass, will need more calories than a female. And what do you know about dieting as far as males and females go? A male can cut out one thing and lose 10 pounds in a day. A female cuts out 5 different things for 3 weeks and doesn't lose an ounce. So a male's ability to lose and also gain, you know, is different than from a female. Okay. Females, of course, have more fat storage because it's just the way our bodies are built for childbearing and everything. Okay. Ethnicity and culture. Are any of you all have any cultural or ethnic differences in your food or your what you eat, your food preferences or anything? Anybody? All right. Well, there may be some, you know, depending on what culture you belong to, how you celebrate holidays, or your different holiday meals and stuff like that. Any beliefs about food? Have you heard of anyone say that they have a belief like you shouldn't eat this food or that food at a certain time or what? Well, yeah, well, those are some specific things, yeah. Right. Okay, that all sugar is considered bad. Yeah, okay. So different things. So it depends on your patient. Personal preferences. What does your patient like? What do they want? If you give me oatmeal, I don't like oatmeal. Don't give me oatmeal. You can give me grits or cereal or something, but not oatmeal. You know, so it just depends. You know, what are the personal preferences? What about their religious practices? We have a few different religious practices, and I'm going to just call out a few, and let's see if you all can come up with what you know about them, okay? What about the Mormons?
They don't drink alcohol.
No alcohol? No alcohol, tobacco, caffeine, things like that. Judaism? No pork? Kosher foods? What? Can't mix meat and dairy. My son was at Metairie, and the people next to him bought a house, and they are of the Jewish faith, and they redid their whole kitchen. They have 2 stoves, 2 refrigerators, I think 2 sinks, 2 set of dishes, because they do not mix meat and milk. Okay? They eat only fish with scales or without scales. I don't know. But anyway, they fast at certain times between, for the Sabbath day, which is Saturday for them, they fast from Friday evening to Saturday evening. They cannot do any work, so they cannot cook on the Sabbath. My sister has a oven that has a Sabbath setting on it. So evidently Friday you can set it so that it will automatically come on at a certain time and go off so that you could put something in the oven to cook, because turning the knobs and stuff is considered cooking for some of the very strict Orthodox Jewish people. Another sister had her knee done up in New York City at this huge orthopedic hospital that was 10 floors of orthopedic surgeries and things, and they had a Sabbath elevator that on the Sabbath it stopped at every floor, going up and coming down. So if you were Jewish, you did not have to push the buttons on the Sabbath. So it's different, beliefs and things. My brother, who was a meat packer a long, long time ago, was fixing meat for a kosher market, and the rabbi had to come and slaughter the cow so that it was bled a certain way, so that there was no blood in the meat and that kind of stuff. So those are their beliefs and everything. Muslims, what do you know about Muslims? No pork, alcohol, caffeine, and they have the month of Ramadan, which is a month of fasting from sunrise to sunset. And I read an article not too long ago that they are really having a problem with people who stick to that, especially diabetics, because their blood sugars are so thrown off because they fast all that time. And so they have people coming in with their blood sugars very uncontrolled. And so if you have a patient in the hospital who's a Muslim who's following Ramadan, that fast during Ramadan, you really need to be watching or be aware that their blood sugars may be really different. And maybe during the day they don't need that insulin because they're not taking in any food, but then at night when they start eating, you're going to have, her in the back, eating watermelon. Okay? I'm sorry, I didn't mean, when I saw it was like, Lord, watermelon. All right, Christianity. Oh, I know, you're not supposed to, that's a food belief. You don't mix watermelon with milk. Isn't that right? Have y'all heard that? I'm almost sure when I was growing up, it was watermelon and milk. You didn't eat the two together. I don't know. Okay, anyway, Christianity. What do you know about, what? Christianity. Lent? Okay, you don't eat meat on Fridays and stuff. And Hinduism is no meat, alcohol, fish, some shellfish they'll eat. But you gotta you gotta respect their religious practices. You cannot just dismiss them and say, oh, that's a bunch of bull or something. But you have to respect that. And you may need to consult with the dietitian to find out what can we supply for them to eat while they are in the hospital, because they have these different religious practices and all that. Okay? What about lifestyle? What about patients who live in an area where the only grocery store they have is a little corner grocery store, a 7-Eleven or something like that? What are the prices of the food at a 7-Eleven versus the prices at Walmart? All right, so much higher. So they're going to be restricted on what they can buy and everything. Economics, what can they afford? What can they buy? There's a high cost of healthy food. Fast food is very cheap sometimes. You can get this $1 this and $1 that, and that meal and this meal. So your healthy choices are sometimes more expensive. There's a widespread availability of fast food places, especially in the New Orleans area, for sure. There's widespread advertising of less nutritious food and healthy food. Lack of access to safe places to exercise, to walk to the grocery store, all of that's going to impact people in certain areas as far as what they can obtain for their, nutrition-wise. What about alcohol and drug consumption? Are they drinking and they don't eat? Are they using all their money to buy drugs and they're not eating? So you got to be aware of that. And then all of these are going to, lead to obesity, because they're not going to be adequately nourished, or they can lead. All right, so what I want you to do now is to, for a few minutes, take out your phone and look up your favorite fast food, the standards for a healthy diet, okay? We have our dietary reference intake, which is tells us what's the acceptable range and everything else. The USDA, U.S. Department of Agriculture Dietary Guidelines, this does not give you specific numbers or amounts or anything else. It tells you in general how to have a more healthy diet. And if I call out a food, you can tell me what this dietary guideline says. So what about foods with sugar? What should you do with those? Decrease, okay? What about vegetables and fruits? Increase. What about milk? Well, what kind? What should you use? Fat-free or skim or something like that, right? What about physical activity? What about alcohol? What about salt? So, and essentially it tells you that's how you're going to have, those are your dietary guidelines. They put these out every 5 years, and I can't tell how they're going to change much, every 5 years. But anyway, they do. Your dietary daily values are from the FDA, and that's essentially what's on your food labels. It's based on a 2,000 calorie a day for children, like over 4 years old. So you got to remember this stuff like My Plate also is not for children. I think this refers to children over the age of 2. But remember we used to have what? The food guide pyramid? And so they went to My Plate. They thought it was more visual. It sort of helped people see that sort of in general, you need more vegetables. You need protein, grains, fruits, dairy. So it sort of gave you a more visual picture of what you needed and everything else. However, it's supposed to balance calories, control portion size and everything. But what is missing? Water, yes. The nutritional, that thing that you need to have. So you need to make sure that people realize that they need water. You also need to be aware of your food labels, all right? So the important thing to recognize is that this is 2 servings in this whole container. 1 serving is a cup. So if I eat 2 cups, how many calories am I going to consume? 540, okay? So it gives you the fat that you should have. You shouldn't have any more than 3. This is the percentage per day that the person needs. How much is in it? This is the percentage. It doesn't give you any saturated fats, no cholesterol. Sodium has 130. What you should have for low sodium is 140 per serving. There's a good amount of dietary fiber and everything. No sugars. Protein is good too. All right? But the important thing is to recognize, that not everything is 1 serving. That this is, if you eat the whole thing, you eat in 2 servings. So twice the amount. All right? Okay. Let's look at some of these different alternative food patterns. All right? So you might need to consult with the dietitian to be sure that the person who follows any of these is getting adequate the nutrients and all. And this can be based like on religion, culture, whatever, or just food preferences and all that. Vegetarian diet, of course, consists primarily of plant food, but an ovo-lacto-vegetarian also eats eggs and milk. A lacto-vegetarian will drink dairy products and stuff, but not eat eggs. So it just depends. A vegan, of course, is only plant food. All right? So they don't have like a single source of protein. So what do they need to obtain protein if you are a vegan? Soybeans, peas, legumes, all those kinds of things, okay? All right, very, very important that they get enough of that. Children who follow a vegetarian diet, may be especially at risk for protein, decreased protein, and some vitamins and things. So it's really important that if it's a child is following this, that they get supplements and stuff like that, or they eat enough of the protein sources to be adequate for, growth and development and all that. All right. A fruitarian is only eats fruit, nuts, honey, and olive oil. And a Zen macrobiotic is brown rice, grains, and herb teas. And this is sometimes nutrition poor, and so you need to be very cautious with them because they might not be eating properly. Getting enough foods and things. All right. The nursing process, of course, we're going to want to promote healthy eating, encourage children and adults to maintain an active lifestyle. So we're going to look at assessment now. So you're hopefully going to identify people who are at risk or those who with a poor nutritional status. So let's look at some of the different things that we're going to look at as far as the history. What is the patient's habitual intake of foods and liquids? You might want to have them fill out a food diary. What do they eat for breakfast mostly? What for lunch? What for snacks? What for supper? How much? What liquids do they drink and everything else? Information about their personal food preferences. Is there some food that they just cannot stand? Turnips. Or something like that. Any food allergies. My granddaughter has multiple, she's almost 3, multiple food allergies. She gets itchy all over. Never breaks out like in a rash or anything, but just, she itches. It's everything. All dairy, milk, she's on, I don't know what kind of milk now. They found out she was allergic to almonds, so she couldn't drink almond milk. I think she's maybe on coconut milk or some other kind of milk. Eggs are out, cheese, dairy, everything. Anyway, cultural background, like what influences that? What are their religious food patterns? Their socioeconomic status, how are they buying their food, and are they being able to buy sufficient healthy food? Psychological factors, when do they eat? Do they eat when they're happy, when they're sad, when they're stressed, when they're all of the above? Can they obtain food? Who shops for the food, and who cooks the food? Because you can be telling this person all of this stuff, and if they can't get the food or they can't cook it themselves, then that becomes a problem. And then what is the patient's general nutrition knowledge? All right? Yes.
I'm trying to figure out, when would you ask all the questions? Would it be during the assessment and health issues?
Yes.
Or would it possibly be during teaching?
No, I think you would need to know before you start taking care of the patient if you recognize that there is a possible problem, because then you want to be implementing stuff at the very beginning. So maybe, yes, when you sort of do your initial interview, find out about their food preferences, what they usually eat, what's your usual diet, and things like that, to get some idea, all right? When you do your health history, you're going to look at comorbidities. That means like what other diseases and everything else do they have that you need to be aware of, because you might have a patient that's a burn patient, but they're also a diabetic. So their need for the protein and all for the burns may be offset by the fact that they're diabetic and you have to control their calorie and their carbohydrate intake. So they have comorbidities that may be involved in what you're doing for your patient. But their food and medicine, their use of illegal drugs and stuff, their use of vitamins and herbal supplements and all. So what herbal supplements are they on that could possibly affect what their intake? Prescription and over-the-counter. Then dentures. Do they have mouth pain? Do they have difficulty chewing? What about foods that cause gas, heartburn, reflux? All of those kinds of things you would want to find out about. Okay? All right. So, what about lab values? The lab value that we're going to emphasize is your albumin level. Okay? Your albumin level gives you a long-term time view of your patient's nutritional status. because it tells you about what their nutritional status for the last 21 days is, because it's based on the albumin and all that's associated with the red blood cells. So you know that the norm is 3.5 to 5, okay? You can have a 300-pound person come in and they can be malnourished because they have an albumin level of 2.1. You know, you may think, oh, they're not malnourished. Well, yeah, they are, because their albumin level is 2.1. All right? They may be very heavy and everything else and obese, but they don't have that protein, that albumin, that muscle mass and all, probably because they have not been eating well over that long period of time. Another one that you see that you don't see as often is what's called the pre-albumin. And that gives you a short view, like 2 days. Like, what is their albumin level over the last 2 days? And the norm here is 15 to 36. All right? So if I have 17 to 40 on your handout, change it to 15 to 36. Okay, it's okay? All right. Grams per deciliter, I think is what it's saying. Okay? But this is going to tell you, like, they could come in and they could have been healthy and everything else all along, and then just the last 2 days, because of whatever happened, their albumin level has dropped, and it's, you know, so you're looking at the pre-albumin. So it's giving you like 2 different pictures. Okay, and then of course your hemoglobin, 12 to 18 is important to look at too. All right? So just think of your patients who may have a decreased albumin level. Think of a burn, who is a person with burns, who has these weeping large areas that are weeping fluid. They're losing a lot of protein and albumin through that fluid that's coming out through the burns. Someone who has hemorrhaged, someone who has renal or hepatic disease may have problems with their albumin and everything else. Someone who has drains, like a large wound that's draining a lot of fluid, and things like that. You know, usually that's serous, that's protein, that's all that's being used. Maybe if they have problems with their GI tract, steroids can change it and all. So it's a differences. All right. Your tricep skin fold, your mid-arm circumference, you know, is measuring this and measuring this. And just, if you ever want to look at it, it's in your book, but a dietitian is going to look at this information and determine the person's status and all that. All right. Your physical assessment, like we talked about, height, weight, your ideal body weight. You know, if you're 5'4" and you're small frame, you should weigh this. If you're medium frame, you should weigh. If you're large frame, you should weigh that. All right. You might also just look at the patient's muscle mass. Look at their strength, their energy level to give you some idea of what nutritional condition they're in, and the body mass index. Okay, we're going to be looking at that in just a minute. What about your patients who have dysphagia, difficulty swallowing? All of those patients who might, just from aging, stroke. Your patient may be NPO until they're seen by speech therapy and have a swallow study done, or a barium swallow x-ray done and everything else. Your patients with different neuromuscular diseases and everything, diabetic neuropathy, head and neck cancers and all, trauma, surgical resections and everything else. So what's going to happen? If they have trouble swallowing, they're going to be aspirating. So the fluid is going to be going into their lungs. All right? You can have such a thing as silent aspiration, where the person does not start coughing and gagging. It's just that fluid is just seeping down into their lungs. I told the other class that I had of a cousin by marriage, first cousin by marriage, who had this because she had terrible reflux disease. She just had terrible gastric reflux disease, and she would get pneumonia, and they recognized that it was because When she had the reflux, it would just go down, seeping into her lungs, and she never realized it. It didn't cause that gagging or anything like that. She ended up dying from pneumonia because of that. But a lot of times you will have this coughing and gagging and all that, but sometimes you don't. So it's really important to pay attention, and we'll talk about using how we handle patients and feed them and everything else. You have a picture, or a form in your book that gives you a nutritional assessment. Just look at it. It's on 1144 and 1145. Just be aware that it covers many different little areas, and it has this worksheet and that worksheet and that worksheet and that worksheet. So it covers all kinds of things to get a nutritional assessment. So let's look at BMI. How many of y'all know what your BMI is? Your body mass index is a measure of the fat based on your height and weight. This is the formula, but you don't have to figure that out. This is what's called underweight, normal, overweight, obesity, morbidly obese people with a BMI greater than 40. Okay? All right. So you have this. That is a nice way to figure out your BMI. You have your height along this axis and your weight along this axis, and you pull the two together and get your BMI. If I was 6'2" or 5'9" or something like that, I'd be happier. So you can't change the height. So the only way you can change your BMI is the weight thing. So everybody's got their BMI. You can see what y'all are. So where do you fall in this area? All right. So we can tell our patients, you can say you weigh 180 pounds. If you lost 10 pounds, your BMI drops by 2. If you're 5 feet tall, your BMI drops by 2. So maybe a drop of 30 pounds down to 150, you're now down to a 29 when you're considered just overweight instead of obese. So it's a small increment that helps them see that reduction in the BMI. And this is something, y'all are supposed to be recording your patients' BMIs every week, right? Y'all have something that you're looking at to get your patient's BMI, right? All right, okay. All right, so what nursing problems or nursing diagnoses can you come up with? Of course, possible risk for aspiration, diarrhea, deficient knowledge. Maybe they don't know about calories, or they don't know about this, or they don't know about that. Maybe they're ready to really improve their nutrition. Feeding self-care deficit. On your list of nursing diagnoses, all of your self-care deficits are under major concepts. You have a feeding self-care deficit, bathing, toileting, grooming, all that. But a lot of your patients, how many of y'all fed patients this week or fed them in the nursing home, I'm sure. So feeding self-care deficit. They may have impaired swallowing. They may be overweight or obese, or maybe opposite, imbalanced nutrition, less than body requirements. So what nursing diagnosis or nursing problem can you identify for your patient? Okay? All right, so we're going to plan. Our goals, hopefully modify the diet. Are we going to plan to modify the diet, to maybe increase exercise, whatever it's going to be? Our goal is for them to obtain adequate or stable or optimum nutritional status. So if you have a patient who has a nursing diagnosis of imbalanced nutrition, less than body requirements, what will be your outcome? That instead of an imbalanced nutrition, they will have balanced nutrition, right? What are your long or short-term goals? That they may gain a certain amount of weight. And what would be the normal gain that you would want them to have? Like how much, over what period of time? 1 to 2 pounds a week. Just like weight loss is 1 to 2 pounds a week, weight gain is 1 to 2 pounds a week. So what are you going to tell them to do as far as your interventions? Eat 3 huge meals every day? No, maybe more frequent small meals throughout the day, with supplements, and that kind of stuff. All right? So you just ought to think of, what do I need to accomplish for this particular patient? And of course, you always want to make sure that your interventions are based on what their preferences are. You can recommend all of this kind of stuff, but if they hate that food, they're not going to eat it. Okay? All right. So you're planning, you're going to set those priorities. You're going to develop a plan of care that includes the patient, the family members, the whole healthcare team. Because it may be very well that it's the family caregivers who are going to be taking care of this patient, providing them with the nutrients and the food and everything else that they need, encouraging them to eat, providing them with the supplements and everything else. And it really involves the commitment and involvement of everybody for that. All right? And collaboration, of course, we talk about the dietitian is so important, maybe a nutritional support clinical nurse specialist. The pharmacist may be involved if they need certain medications, supplements. Did you all give any appetite stimulants to any of your patients last week? Anybody received an appetite stimulant? All right. We had a lady who was on Marinol, which is essentially medical marijuana, because she had such poor appetite. She was getting it twice a day. But she received that. Sometimes you have patients on a drug called Megace, which is really an anti-neoplastic drug, but it's a side effect that it increases the appetite. So you may be giving a patient medicines that stimulate their appetite and everything too. Okay? Long-term management, that's the thing. Weight and nutrition does not change overnight. It's going to be long-term, weeks, months before you can achieve this goal or that goal. Okay? All right. All right, I think we're going to go stop for a second now for about 5 minutes, and then we'll go forward after that. Okay? Yeah. What?
What's associated with?
Oh, I said changes in their metabolism and absorption. Okay.
And skip Zen macro.
Yeah, no, it was the ones that are fruit,
Oh, the fruit
nuts.
ones?
Wait, that's the fruitarian. No, the Zens were even less. They had nothing. Brown rice, grains, herb teas and stuff. So just like brown rice and grains and stuff. So that's all they eat. The fruitarians are the fruits, nuts, and stuff.
Rice, grains. Okay.
Okay? All right. Shoot. Okay, we're going to talk about, all right, alternative feeding methods. The best way for a person to receive nutrients is through the GI tract, of course, by eating and everything else. Sometimes if they cannot eat food for whatever reason, then they might give them enteral nutrition. We're going to be talking about enteral nutrition and parenteral nutrition. Right now we're talking about enteral nutrition. That means food that's given along the GI tract through like a nasogastric tube, a PEG tube, a jejunostomy tube, something like that. All right. All right, so what are some of the complications if the person has that tube in their throat or in their stomach? One of the main things is what? Irritation, aspiration. That's why it's so important that the patient has the head of the bed up 45 degrees, at least 45 degrees, that they, if you are going to lay them down, you're supposed to turn the tube feeding off. You need to make sure that it is regulated at a continuous rate, because if they get it too fast, all that food going into the GI tract at one time can cause a shift of the fluid into the GI tract, causing osmotic diarrhea. They just have this huge diarrhea because all of the food's coming in, the fluid's coming in, and it's all going out. Okay? So all kinds of complications. Let's see. The important thing as far as nursing care goes is to follow your tubes. When you're looking at the patient, they're receiving something like this, maybe in a container like this, manufactured by some company. It might be a Jeopardy or something else that has a certain number of proteins and all that. Usually it goes through some type of pump into the GI tract, into the stomach, through the PEG tube, or maybe through an NG tube. But you follow your tubes. If it's in the nose, you make sure it goes through here, and what if it's coming from? The same thing, okay? Always follow your tubes from one end to the other. A lot of times with patients who are getting enteronutrition, they will have a type of pump that allows two things to, it's like a dual chamber pump, one for the feeding and one for water, because you still have to give the patient water along with the tube feeding, and you can set up the pump in such a way that it automatically puts in so much water every, so often. This is usually started off very slow to see that if the patient's GI tract can tolerate it, maybe 10, 15, 20 milliliters per hour. If they tolerate that, they'll bump it up 10 milliliters. They tolerate that, pump it up every hour, 10 milliliters, until they get usually around 60, 70, 80 milliliters per hour is what they usually want them to receive. Okay? All right. So, what is the hallmark way of telling that this NG tube is in the right place? Hallmark way. X-ray. Okay? To verify that this tube is in the right place. I read an article about tubes being in here and down here and up in here and everything else. And when they looked back, it was that most of them were not verified by X-ray. Right? X-ray is your hallmark thing when you put an NG tube down and you're going to feed the patient, that you verify that it's in the right place. After that, because you can, of course, you cannot X-ray someone every time you feed them or every few hours, something. What is the hallmark way? The pH of the aspirin. Okay? All right, so you check the pH to see if it's acidic, less than 6. If it's in the GI tract, hopefully you can tell. The very last, but the one thing you're going to see is that air in the syringe with your stethoscope over the stomach, and see if you hear that swish of air. You're going to see that, but it is not a really accurate way to tell, because if it's up here in the esophagus, in the trachea, you might very well hear that. It's not that far distance or anything. Okay? All right. So this is a continuous feeding. The person is on it, all the time. You can also have what's called a bolus or intermittent feeding, where you go in every 4, 6 hours, something like that, so many times a day. Give them maybe a can or two of Ensure or Jevity or whatever is ordered. You let it flow in. You give them water also, usually. Well, you do need to give them water, so, you're going to flush it before, flush it after. You have to keep track of all those numbers and everything else. But then once they're finished, this tube will just be clamped off, and it will stay in the person until 4 hours later when they come and give them the feeding again. So it can be either continuous or bolus. All right? Let's see. All right. said that. All right, this is like a peg tube or something. Checking the pH. All right, this is parenteral nutrition. Remember when we talked about parenteral medications, we said that those were medications that were given sub-Q, IM, intravascular, all those kinds of things. This is parenteral. That means it is going into a vessel, all right? It might be going into this peripheral area, like with a PICC line, a midline, a subclavian, a jugular vein, but they all end up in this superior vena cava, which is a very rapid or very high flow vessel, all right? Your problems with this are, of course, it's an IV access, so you have problem with possible infection. You have problems with maybe it becoming clogged. You have problems sometimes when they put it in of puncturing the lung. What else? Let me see what else I have. An air embolism, or again, if it's not correctly regulated, you could have osmotic diuresis, where all of this stuff is coming in, all the fluid shifts into the intravascular space, and the patient, it becomes fluid overloaded, and it has to be, diuresis and everything else, and very severe. The problem with this, too, is this is usually a higher glucose concentration. Most of your IVs are dextrose 5%, D5W, something like this. This may be 10, 20%, 50%, or whatever. Somebody said your patient was on TPN, did you notice what dextrose concentration was in the fluid?
No, it was huge.
Yes, it's a big bag. Right. Okay. All right. So, the care, again, I can't emphasize enough how important it is to follow your tubes, to make sure that because of the high dextrose concentration, that blood sugars are checked routinely. Even though the patient is not a diabetic, they're on Q6-hour glucose checks because of the high glucose. This is usually what the bag looks like, something like this. It's yellow because it has vitamin C in it. It has all kinds of nutrients. When you look at the bag, all kinds of electrolytes, nutrients, proteins, amino acids. It usually has insulin in it already, even though you're checking the blood sugars and all that. Well, a banana bag is sometimes anything with the yellow in it, but it's yellow because of the vitamin C that's put in it. But look at this. What does this look like? Does this look like milk? Yeah, So this, however, is lipid. And every so often they give them a bag of lipids. It might be every day or so many times a week because they don't get any fat or anything in this. But this is lipids that are infused intravascularly. So that's why I tell you why it's so important to follow your tubes, because this looks like the formula, right? And there was a situation I heard about, and one of my students who worked somewhere also heard about a situation where a bag of enteral formula, that was white, was hooked up to this. So can you imagine, like, Ensure going into your vascular tree? Well, the patient died, So that's why it's so important. If I know this is lipids, I need to make sure that it goes in there. And if this is a formula, a tube feeding, enteral feeding, that it's going into an NG tube or a PEG tube or something like that. Follow your tubes from the site to the bag or from the bag to the site. Okay? Very, very important. Once a patient is consuming food through the GI tract, about 75% of their nutrients, they will stop this. Because this has such inherent complications and everything associated with it. They don't want to use this unless they have to. And they might, if the patient is has absorption problems, or they just cannot meet the nutritional needs enterally, they will feed them parenterally. Maybe they have some type of problem that the GI tract just is not working at all. So you might see this. So someone who is very, very sick and they need to get that nutritional level back up again. All right. Okay, parenteral. Okay. Health promotion. We have our Healthy People 2020. Obesity, 35% of prevalence in the United States. And remember, to lose or gain weight, the calorie intake has to exceed the output to gain weight, or the calorie intake has to be less than the output to lose weight. All right? So it's calories and calorie expenditure. So how many calories do you need to expend or to save in order to lose a pound or gain a pound? How much? 3,500. All right? So if you can cut your calorie intake by 500 calories every day for 7 days, that's 3,500 calories, you should lose a pound. If you need to increase it, then you need to increase your calories 500 calories over what your body expends in order to gain a pound. So you can see why diets that have you losing 10 pounds in 2 days are not going to last. Because when you go back to your regular eating habits, you're going to just gain it back, you know. So it's slow. That's the problem. Like I said, it's a slow process. 1 to 2 pounds a week. So if you have to lose 100 pounds, you know, because some of these morbidly obese people have to lose 100 pounds, that's like 2 years of dieting, or 2 years of watching, you know, how can you, you know, like that adherence to that compliance with, you know, a diet and fluid restriction, intake, food restriction. All right. Fruits and vegetables are good. Okay, all right. Acute care. Okay. All right, so let's look at all of the different things that we're going to help this person promote their appetite, assist them, and all that kind of stuff. Okay, all right. Sometimes your patients will have different devices to help them eat, like a large handled spoon, or maybe a sippy cup, or maybe a plate that has a border around it so they can scoop their stuff up and it doesn't all fall on the table. There are a few pictures in your textbook. Just look at those just so that you're aware of those. Try to help the patient be as independent as possible when they're eating. Give them the napkin to hold, or give them the slice of bread to hold, or whatever it is. Eating should be a social, enjoyable time. So if you're feeding a patient, sit down, take your time, all of those kinds of things. Okay? Like I said, small, frequent meals are better than just trying to get everything in at one time. Remember also patients who have had throat surgery or neck surgery or anything like that, you should, cold, mild foods are better. Hot, spicy foods they're not going to be able to tolerate. Also, if they've had surgery in that area, you should not give them anything that is red, like red Jell-O or red popsicles or anything, because if they vomit, you can't tell if it's blood or if it's from the Jell-O or whatever. So it shouldn't be like a red. If they have visual disturbances, what are you going to do? Tell them that their food looks like a clock, you know, and this is at this side, this is at 3 o'clock, this is, all right, so give them that kind of cueing. If they're paralyzed, you put the food on the good side, okay? If they have dysphagia, you're going to feed them slowly, small bites. Make sure that they swallow, and we'll go over that a little bit. How are you going to stimulate someone's appetite? Like I said, make it pleasant. Get rid of odors. Don't have a urinal sitting on the bedside table next to the tray. Give them oral hygiene. Have them wash their hands before. All that kind of stuff. Years ago, there was a CNA, Ruby Johnson, who was working at Charity where I was working. It was a 10-bed ward. It was a woman's ward. And we had patients in there that had mastectomies, because at that time they were doing, radical mastectomies and everything else. And one day, Ruby took her lunch, and I saw her walking to the back of the ward to sit next to this bed that this woman was in, who was very depressed about having the mastectomy. And Ruby sat there with her lunch while the woman was eating her lunch. I was just talking to her and everything else. And it was like, I just remember that from, I can't tell you how many years ago, that she took that time and effort to spend her time, her lunch time, with that patient who needed that, company and everything else. So just remember those things. You remember those things. Okay? All right. Let's see what else. Okay, of course, evaluation, you're going to see if the patient is meeting any of those goals and everything else. Have they changed their exercise plan? Have they noticed a change in their weight? That scale just does not move, and I know from personal experience. All right. Restorative and continuing care. So we're going to look at this medical nutrition therapy. So what diets are people on because of their medical condition? So you might have a diabetic, and they are on an 1,800 calorie ADA diet. Or were any of your patients this week on ADA diets? That's the American Diabetic Association. So the calories are adjusted according to the food pattern and everything else that the American Diabetic Association suggests for an 1,800 calorie diet, a 1,200 calorie diet, or whatever it is. You might have someone on a restricted or low sodium diet. Usually that means that they shouldn't be consuming more than 2 grams of sodium, okay? You might have a low carbohydrate diet, a low fat diet, a heart healthy diet. So different diets that you will see based on your patient's condition. You will also see diets that are like this depending on your patient's medical condition and how they're progressing. So let's look at each one. So a clear diet is what? Clear broth, jello, carbonated beverages, fruit juices, things like that. Things that are liquid at room temperature. So something that's clear is liquid at room temperature, they can have it. It would be like juices like apple juice, grape juice, cranberry juice, okay, things like that, all right? The next one is a full liquid diet. This would include juices like orange juice, pineapple juice, those things that have pulp in it. Also, ice cream that would, melt at room temperature, custards maybe, not at room temperature, at body temperature. So what's gonna, those full liquid things. Remember, nothing red, like I said, if it's because of someone oral problems or stuff like that. Pureed is things that are put into a blender and blenderized. So these things really look like a piece of meat and an ear of corn. That's not. That's pureed food that is then put in like a mold to make it look like the food that it's going to be. Okay? Like those peas. Those are not, those are pureed and then it's put in a little mold so it gives it the shape of the food. But it's like blenderized food. Pureed for those patients who have trouble chewing and everything. All right? Mechanical soft. Like mashed potatoes, your cooked soups, cream soups, fish, flaked fish, chopped up or diced meat and stuff, rice, potatoes, cooked vegetables, cooked fruits, bananas, peanut butter, eggs. All right. So mechanical soft. A soft, low residue. You don't want a lot of fiber in this. So it might be, easily digested pastas, moist, tender meat, canned, cooked fruits and vegetables, cakes and cookies without nuts and fruits. high fiber, now you want all the nuts and fruits and raw vegetables, fresh fruit and things like that, bran, oatmeal and all. All right. And then we say a regular diet. When your patient is on a regular diet, that does not mean they're on a diet like we think of diet. It means just a regular food. They can have anything they want. There's no restrictions. Okay? Our exemplar, question. Okay. Full liquid diet would include which foods? Select all that apply. Would it include gelatin? It includes the clear liquid diet, because if they're on a full, it would include the clear. So they could have gelatin, popsicles, ice cream, and milkshake. Right, they couldn't use the creamed potatoes. Yeah. Wait, what? I'm sorry. Yes, but it would have to be coffee without cream or anything. It would be clear, yeah, because you can see through tea and stuff like that. Mm-hmm. No, full is the more the cream, milk, ice cream, puddings, that kind of stuff. Okay? Milkshakes and all that. Okay, so our exemplar is obesity. Okay? Excess of adipose tissue, most prevalent preventable health problem in the United States. 35% of adults in the U.S., 17% of children. That's getting worse and worse every time you read something. What is the big problem with obesity? What disease do you see? Diabetes and what else? Heart problems, hypertension, strokes. Everything is going up for people in these categories. All right, let me see if hopefully I got this. Now pay attention to this with the dates are going to change at the top, and, oh, shoot. Oh, man, it was there before. Oh, no, that's not it. Oh, no. Oh, I'm going to have to find this for you. Oh. Yeah, I can't even spell YouTube. Oh, GB, thank you. Oh, it came up last time and I forgot to,
So you.
Okay. It doesn't give me like my last YouTube things I looked at. YouTube search. Can I put it up here? I don't know. Okay, let me try that. Thank you. That's what I did last time. Good. Oh, it's coming up. Thank you, copy here. Paste. Thank you. Let's see if it'll come. Nope. Put it up here or here? Here? Right here? And it paste? Is it going to do it now? This is it. Wait, 3 seconds. Okay, come on. I thought I was going to skip the ad. All right. Pay attention to the dates up here and this down here. Thank you. Don't you like the music? Okay. Okay. All right. So somebody said, "Thank goodness for Mississippi, because otherwise we would be the worst for everything." All right. And this only went to 2010. So this is like 6-7 years, so I haven't only knows, but how it is, progressing, really. All right. So obesity occurs when excess calories, I'm going to go through this pretty fast, all of this kind of stuff. Okay. Genetics. I don't know. This says 25 to 40% rate based on genetics. I think that's still sort of out, whether or not it's genetics or lifestyle. Like what you learn when you're a kid and how you behave when you're a kid. Does that probably have, I don't know. Yeah, So I don't know. 25 to 40, and a lot of times people, it's my genes. Well, that can be a big excuse for somebody, when it's like, well, even if it is your genes, you can still, hopefully regulate it in some way. Physical activity is so important. Environment that's going to contribute to it, and everything else, and those psychological factors. All right, let's look at what the risk factors are for someone who is obese. 60% of them have what's called the metabolic syndrome. A metabolic syndrome means that they're obese with excessive abdominal fat. They have hypertension, increased lipid levels, and insulin resistance. All right? That makes a metabolic syndrome that puts them at more and more risk. All right? Increases risk of insulin resistance, type 2 diabetes, reproductive function, all of these problems. You can imagine osteoarthritis, they're carrying around an extra 100 pounds, Did I tell you all that? Somebody I know said they had lost like 50 pounds, and they always thought of it as like a bag of dog food. Those big bags of dog food, that they were no longer carrying around the huge bag of dog food. So you can imagine this. Remember, it is so slow, the process. It can become very depressing because you feel like you make no headway. And you look at that scale, and in order to see 1 pound a week is really hard. Sleep disorders, they can't breathe because their abdomen is pushing up. They have all kinds of sleep disorders. The abdomen is pushing down. They have stress incontinence, lower back pain, post-operative complications. They have all this adipose tissue. Remember, adipose tissue does not have the vascular system that your muscles have. So if you have adipose tissue that you're cutting through, it's going to be harder for it to heal. All right? Okay. All right. We already went through this about what the different ones. And the upper and body waist, waist to hip, do have a like an impact, but I'm not going to go into all that. Okay? Treatment is complex. We know that. Look at that. A BMI over 40 means that they're 200% of their ideal body weight. So that means if they should weigh 150, they're probably weighing 300 pounds or more. So like I said, if you have to lose 150 pounds, to get, or you're looking at 3 years of, trying to take that weight off and everything else. All right, there are different tests that may be done in different areas and things like that, but just I'm not looking at underwater weighing or bio. Okay, your different diagnoses that can affect the person. Non-compliance, non-adherence. Like we said, this long-term care. Long-term. Goals, hopefully, to make sensible dietary choices. Follow that exercise routine. Try to figure out strategies to deal with the hunger. So if they're hungry, should they drink a glass of water? If you get hungry, maybe go for a walk. If you get hungry, go read a book. If you get hungry, try to come up with different areas different things that they can do. Attend support group meetings. Things like exercise and behavior modification. So are y'all aware of any behavior modification things that they suggest? I've always heard, you put your food on a small plate because it looks, like you have more food. You put the food on the plate. You don't put the pots on the table, or something like that, that you serve your plate, you sit down, and that's what you eat. What? Put your vegetables in so that it covers a bigger area, that you drink water with your meal or before your meal, that you put your fork down every time you smaller plate, yeah. Chew, put your fork down between meals because they say, your stomach takes about 20 to 30 minutes to recognize that it's hot, that it's full. And so by that time, you're probably eating 3 servings, instead of just doing it more slowly and all that. So hopefully all of those things will help. Exercise, they say, 30 to 40 minutes of exercise, like at least 5 times a week or something. So if your patient is walking 10 minutes a day, maybe next week they can walk 15 minutes, and maybe next month 20 minutes a day. Small increments, that's what it's going to, and things that they can stick with, all right? Okay. Expected outcomes. We've got that. Y'all have all that. Exercise, like we said, focus on reducing the health risk. Maybe not, focus so much on reducing the weight, but the health risk. You have to look at different medicines that they may use, the appetite suppressants and everything. And then, of course, your surgery, exercise, like I said, 30, 45 minutes, 5 times a week. Bariatric surgery, maybe a gastric sleeve or a band. I've seen people who have had this, different types of bariatric surgery, and they can eat when they first get out, small amounts of protein shakes and things like that as they gradually increase food, because their stomach sometimes is like reduced to practically nothing. The problem is they have to always be aware of what they eat, because even though your stomach is reduced to almost like a little nothing, it can expand. And I have seen 2 or 3 people who lost probably 50 to 100 pounds and have gained it back. Because you still have to, you cannot just eat like you want to, or, like you did before. You have to really restrict it and everything else. Okay? All right. Collaborate or create a diet. Because remember, we said 500 to 1,000 kilocalorie deficit, because you need the 3,500 to reduce. Modification, behavior modification. All right, and I think that is it, but we're not leaving. No. All right. I have a little exercise to do real fast. All right, but we